Thank you for coming. I'm Jerry Isaacson, Director of Research at LifeSci Advisors. I want to thank everyone for coming to the event today for DelMar on glioblastoma. Very happy to have a distinguished KOL with us today, Dr. James Perry. He's the chair of the Canadian Brain Tumor Consortium and also the head of neurology at Sunnybrook Health Sciences Centre in Toronto. He's been involved in clinical trials for pretty much anything that's been tested in glioblastoma, has led many of these trials, and I can attest is pretty much an all-around good guy. After Dr. Perry's presentation, there'll be also a presentation from DelMar, and then at the end we'll open up the floor to questions. Without further ado, Dr. Perry.
Well, thank you for the kind words and the introduction, and thank you all for attending today. I have been involved in a lot of the clinical trials, but it's not my fault that we've seen very little advance. I think it's fitting that we're in the Kennedy room, given the fate of the late senator and his demise due to glioblastoma. And I'm going to talk today a little bit about the therapeutic landscape for glioblastoma as it currently stands. Those are my disclosures. We're going to look at the current treatment standards in glioblastoma, which I imagine most of you are quite familiar with, but then review the pillars of care, which are targeted therapies, anti-angiogenic therapy, immunotherapy, and some novel approaches, and turn back around to the limitations of alkylator treatment as we currently use it and the urgent need for new agents, especially for patients with glioblastoma characterized by an unmethylated MGMT promoter, and I'll go into that and tell you what that means. And between myself and others, we'll review the opportunity for DelMar's drug VAL-083 in clinical practice. So here's a picture on the far left is what a glioblastoma looks like on an MRI scan. It's a big, ugly mess of contrast enhancement. These things create their own blood vessels through angiogenesis, through upregulation of vascular endothelial growth factor. The center of these things become quite necrotic, and then there's an advancing edge. So you see with section A under the microscope, nasty looking areas of necrosis, and in section B, what's called microvascular proliferation, which is VEGF driven. And then C and D, the advancing margins of these tumors as they infiltrate throughout the brain. And on the right side of that picture in the cartoon is just a depiction of how far away from the central core of the tumor that we can see on MRI the tumor cells infiltrate. So they go across the brain into the opposite hemisphere. And that's why in the 50s, when surgeons did things like hemispherectomies, so when a patient had one of these in their non-dominant or right hemisphere that wasn't dominant for language, you would have a hemispherectomy and take the whole thing out, and the tumor would invariably recur on the left side. So this is the limitation of surgery. Surgery isn't, it's very helpful to reduce mass effect. It's never going to be a cure. Radiation therapy is never going to be the answer. We need systemic therapies that are going to be able to get into this mess, especially treatments that can address the advancing edges of the tumor, which are the areas that we currently can't even see on an MRI scan and have a very hard time getting therapeutics to. So in 2017, here's Gary Larson from the far side in a caveman looking through a primitive microscope. It's a mammoth. To the modern neuropathologist looking down the microscope. And what's been replaced in the past year has been a new classification of brain tumors, and this is very welcome. So rather than depending upon histology, brain tumors are classified according to molecular genetics. It's a complicated slide, but things start with this progenitor cell or stem cell, and these are now readily identified both in human brain and in animal models. So a lot of our research works comes from isolating stem cells, creating neurospheres that can be transplanted into a mouse model, so you can recapitulate a human brain tumor in a mouse. And this IDH mutation has really taken our field by storm. So this is the only mutation that happens in gliomas. Gliomas are the category that GBM falls into. GBM is the most common of the gliomas. And this IDH mutation is the only mutation that occurs in absolutely every single cell. So one thing I think on folks' radar is that for IDH-containing, IDH mutated tumors, like low-grade oligodendroglioma and lower-grade astrocytomas, etc., anti-IDH strategies like vaccines and IDH inhibitors are likely going to be a huge thing. Glioblastoma, unfortunately, rarely arises through that IDH pathway. It usually arises de novo, or what's called a primary glioblastoma, through a series of mutations typified by epidermal growth factor receptor upregulation. And that's 90% of the GBMs that we encounter. About 10% come from this process of low grade to grade 3, so grade 2, grade 3, and then grade 4 adult glioblastoma. That's about 10% of them. The important thing is when you're looking at technologies or reading studies is you need to know if a study has included these IDH mutant glioblastomas, because these patients do a lot better. So survival times are years and years as opposed to a year or two for this one. So if there's a mix of these patients in a clinical trial or in some sort of strategic development, it would skew and bias results in favor of longer survival times. Importantly, the incidence of this disease is increasing. It could be considered an orphan disease. We usually read the stats. It's 3 to 4 out of every 100,000 people. But the SEER database, which is in the southeast U.S. in about 12 or 14 states, has looked at these trends over time. And in the 2000 to 2010, the incidence has doubled, especially in Caucasian males, for reasons that aren't clear, but the incidence there approaches 10 to 15 per 100,000. In part, this is because we're detecting them more and operating on them more. To get into the database, there has to be a tissue sample read by a pathologist that says glioblastoma, so more patients are getting operations because surgery is safer. The older population tends to be healthier these days, so. But part of it is likely an actual increase in the incidence of disease. So when these patients come to attention, they have an operation. We know through a variety of studies that the better an operation, the better the patient does. So the more tumor that can be resected and the less residual disease, the better. And from the first principles of any cancer treatment, if you're fighting against fewer residual cells, your treatments are likely to work better. So the idea is to resect. The problem is, of course, is that it's the brain, and the brain is full of all kinds of places that you just can't operate. So the vast majority of patients don't get what's called a gross total excision or a maximal operation. So people need treatment afterwards, always. If a glioblastoma is not treated, life expectancy is about 2 or 3 months. The best evidence for treatment is radiation therapy, so it's given over the course of 6 weeks. Patients come back and forth to a cancer center every day, Monday to Friday, to get radiation, and they get that in combination with an oral alkylating chemotherapy called temozolomide. And then they get at least 6 months or up to a year of monthly maintenance cycles of temozolomide. And in the clinic, although that's standard of care, it's probably only about half of patients that can actually receive that because they're either old, frail, they're significantly impaired neurologically after their operation or after the presentation of the tumor. And we always have a look at the MGMT promoter status, which is an important topic that I'll get to in a sec. So the mainstay, the backbone of our treatment apart from radiation is temozolomide or Temodar. It's a very well-tolerated medication. It's very simple to use. It's really sort of a diet chemotherapy. It's not a difficult one for patients or for docs to use, and we'll go through the evidence that shows that it adds significant benefit to patients when given with radiation. In part, that might be because it's a radiation sensitizer. Important point with this drug is that it's effective essentially only in the tumor cells that harbor MGMT promoter methylation. So that's 40% of glioblastoma patients. So it only works in 40%, leaving 60% of patients without an effective systemic therapy agent. And importantly, even within the 40% that have it, there are different levels of this MGMT products from 0 to 100 on a spectrum. And we know that the more of this biomarker that you have, in essence, the better you're going to do in terms of response to therapy. So this is a sort of cartoon of how this works. So there's a portion of DNA. So there's what's called the O6 position on guanine that gets methylated. So methylation is the addition of an alkyl group, CH3, onto the DNA, which inhibits the ability for DNA to separate and therefore for cells to divide. And in our bodies, we have ubiquitous DNA repair enzymes that are put in there to mop up all the damage we get every day from sunshine and ionizing radiation and just mistakes that get made in our DNA coding on a daily basis. So there's lots of repair enzymes. One of these is methylguanine methyltransferase, and if you happen to have a lot of that in your glioblastoma tumor cell, it just wipes out that alkylator, this alkyl group, and restores normal DNA so it can continue to replicate. And what happens is that MGMT molecule becomes inactivated. And this shows how that inactivation happens. On the top row is the gene that codes for the MGMT protein or enzyme. And if the promoter region, so that's the area before the gene that allows the gene to do its thing, if the promoter is allowed to work, you get the gene product. And there's lots of MGMT around, and that eats up temozolomide, which results in a decreased response to treatment, and in fact, essentially no efficacy of treatment for temozolomide. Whereas in 60% of the patients, the promoter region of the tumor is methylated, which is an extremely common way that cancer cells try to gain an advantage. They widely methylate throughout cells to try to turn genes off that might otherwise try to kill the tumor cell. So if you are, by happenstance, have a methylated promoter region to your MGMT gene, the gene gets turned off. So there's no MGMT floating around in the tumor cells, and the cells are very susceptible to alkylator-based treatment. That's temozolomide, procarbazine, lomustine, for example. And that's specific to what's called the O6 position that I showed you on the DNA. And that's an important distinction that we'll get into later. So the pivotal trial was 12 years ago now. It's called the Stupp regimen because Roger Stupp was the first author of this paper, and the blue line is radiation with temozolomide versus radiation alone, and we saw an improvement not only in median survival, but 2, 3, 4, 5-year landmark survival times. So this was unprecedented in our field and led to a new standard of care. And what's important to understand here is that the concept of MGMT had been known, and so the investigators in this trial looked retrospectively at MGMT in their patient samples. And for patients that had unmethylated MGMT, there was the statistical significance of benefit from temozolomide was lost, whereas patients that had methylated MGMT accounted for most of the responses to treatment. So there's 60% of the patients, and this is 40%, but the 40% that benefited drove the overall trial to be positive. And you can see the dramatic difference from what we used to do, which was radiation therapy alone, where 1 in 50 people lived 2 years, now to methylated patients with temozolomide added to what we always did with radiation. 1 in 2 patients lived 2 years, so from a 2% to almost a 50% 2-year survival. So this is the reason that it was really taken up into practice and is so actively used. Currently, because we don't have any effective agents for unmethylated MGMT patients, we actually give temozolomide to all of these folks too. Largely, there's a couple of reasons. One is that the MGMT test is a bit imperfect and it's heterogeneous, so you may take a sample of a tumor and it may read out as unmethylated where some other parts of the tumor are methylated. That's one. And the second thing is this tail on the curve here, where you can see the numbers are actually bigger, right, with radiation alone versus radiation plus temozolomide. There's a slightly higher survival. So we offer everyone the potential benefit of temozolomide, largely because we don't have anything else to use in that situation. And these are the same data shown in a different way with landmark survivals up to 5 years, showing the benefit, especially in patients with MGMT methylation. And for the first time, this is when we could start to talk about long-term survivorship in the clinic. It was a real change to offer hope to people that there might be 3, 4, 5-year survival, because that wasn't seen before, right? Radiation only in unmethylated patients. Nobody lived past 2 years in the past. So because temozolomide was such a hit, a number of people were thinking, well, what if we gave more, right? So there's different schedules that temozolomide can work in, and one of the ways you can give it is to give it in protracted schedules, where in a given month you give a much greater dose, so it's called dose density or dose intense temozolomide. So this was done by the radiation therapy oncology group, in a trial that started in 2005, right when the Stuck paper was first published. And it basically just added a much bigger dose of temozolomide in a given month, distributed over 21 days. And it was a very successful trial in the sense of its accrual for a relatively rare disease. There were 1,200 patients, eventually, of whom 800 had their DNA available for analysis, and the methylation status was known. And one group got the treatment that you just saw, which was temozolomide with radiation and the standard 5-day dosing. And the other group got high-intense dosing of temozolomide. And unfortunately, it made no difference. And the thought was that if temozolomide was good for the methylated patients, more temozolomide should be better. And if temozolomide didn't work in the unmethylated patients, maybe you could force the curve, the pharmacokinetic curve to influence that. But that did not work, and it was a completely negative trial. We just finished this trial in the elderly because the Stuck trial ended at the age of 70. So along with our colleagues in Europe, Australia, and Japan, we just finished this study of short course radiation with temozolomide. So older patients, and I'm sorry to say old is defined 65 or older, but older patients tolerate radiation treatment poorly, and 6 weeks of radiation essentially puts a patient to bed. People are drowsy, they're debilitated, they do poorly, and randomized trials comparing long radiation schedules to short ones, particularly in Europe, have shown no difference in survival. So a shorter course of radiation has been adapted, but nobody had ever tested chemotherapy in addition to short course radiation treatment. So this paper is coming out in next week's New England on Thursday. And this showed basically the same kind of concept as the Stuck trial did, so that progression-free survival was better. The blue bar is radiation plus temozolomide, but especially so for methylated patients, where you can see a dramatic hazard ratio of 0.33. And we saw no statistical benefit for progression-free survival in unmethylated patients. So again, urgent need for something that works in these folks, these 60% of folks that don't have a methylated MGMT promoter. And overall survival was very similar. So overall survival was superior without regard to methylation status, but most of that benefit for survival was conferred by the methylated MGMT promoter. So survival doubled essentially for patients with this treatment. So we're 12 years later, and where are we, right? We've seen no benefit yet. So taking that backbone, as we call it, of radiation and temozolomide and adding every conceivable drug that we have available has led to no improvements in survival. So and we have no agents at all that can address the urgent need for these unmethylated patients that barely, if at all, benefit from temozolomide chemotherapy. And we've had a bad few years. We've had this, I've referred to the 0525 trial, the upfront Avastin trials. These were hugely promising. So one was academically run through the Radiation Therapy Oncology Group, and one was a Hoffman-LaRoche sponsored trial, the Avaglio trial. In the RTOG trial, the people on placebo did better than the people on Avastin. So Avastin was useless for upfront therapy. Interestingly, though, about 20% of patients in the United States still get Avastin upfront because it pays really well. The Centric trial, which was with selengitide, is an integrin inhibitor, a completely negative trial with that. And we were really hoping that a drug that targeted invasion would be a partner drug for Avastin that targets angiogenesis, and you'd have dual mechanisms, and everything was, we were really hyped that that would change upfront treatment, and it did not. And then recently, many of you might know, the EGFR variant 3 peptide vaccine, which targets one of the major drivers of growth in glioblastoma, was a negative trial. That was a Celldex-sponsored trial, and I'll go through that. So everyone recurs, right? There are no cures from upfront therapy for this. Everyone recurs at some point down the road. And unlike other cancers where current, trials are focusing on what's the best third line, fourth line, fifth line, in breast cancer, it's the sixth, what's the best sixth line therapy. We don't have a standard for second line. It's like completely unclear what we should do, and there have been very few randomized trials to give level 1 evidence at second line. So the stuff that's available to us are these things. So lomustine, otherwise called CCNU, that's the C in PCV, so there's a PCV chemotherapy regimen, but lomustine is used as monotherapy most commonly. temozolomide rechallenge or Avastin. And I'll talk about those. Those are associated with fairly low 6-month progression-free survival. So that's the proportion of patients whose MRI scans stay stable and the patient stays stable for 6 months. So you can see even with, with these drugs, 1 out of 4 people, so 3 out of 4 people progress within 6 months of taking these drugs. So that's terrible. And those are the only things we have. And this is an important number to kind of keep in mind that once the tumor recurs, generally these folks have somewhere between 6 to 10 months left. So most of a person's survival is conferred by the upfront therapy. Once recurrence happens, it's usually a pretty short window, and it's a very palliative treatment. I mentioned those drugs already, and there's a bunch of others that get tried. Just in case you wanted procarbazine, carboplatin, etoposide, tamoxifen, they don't do very much, but they're used a little bit out of desperation. It's a bit of a dog's breakfast at that point, and it's, as I often say, it's like shuffling deck chairs on the Titanic with these. The patient's just going to be doing poorly, and they don't work. Lomustine, we have modern data. There have been a couple of trials where lomustine is used as the control arm in trials of targeted therapy, and none of the targeted therapies have worked, of course, and this is one of the negative large randomized trials of a particular targeted drug versus lomustine. And anyway, it gave us at least good numbers to know that lomustine has a 6-month progression-free survival of about 20%. So it's very helpful for planning future clinical trials, and that's really the benchmark. When people are looking at new agents in this disease, is you got to beat that 20-25%. So people are looking for signal in recurrent disease of 6-month progression-free survival, more on the order of 40 or 50% to have some confidence that a drug is going to be meaningful in clinic down the road. Avastin emerged. It's a monoclonal antibody against vascular endothelial growth factor. Lots of good reasons to try doing this. There were lots of fears of using it in brain tumors because of the risks of thrombosis and stroke, but also bleeding in these patients. So Roche really pushed back a lot when investigators tried to use this because it already had its niche in colorectal cancer and to some degree in lung and ovarian cancer. But finally was used, and some open label studies were done. I'm talking at recurrence now. Remember, the upfront combined with radiation and temozolomide, it doesn't work at all. At recurrence, it has a very robust response rate. So the tumors appear to shrink on the scans almost always. Just based on this response rate, it led to regulatory approval with the FDA, conditional regulatory approval with the FDA, with Health Canada, but was not approved by the EMA in Europe because there were no data to show that it improved survival or quality of life. And this is the kind of thing that was shown, and it is dramatic. That's the so-called waterfall plot. So these are all the patients, and the blue, each blue line is a patient, and each one that's below this bar means that the tumor shrank. So only a few people have their tumor blow through Avastin and continue to grow. So these patients had tumor shrinkage, and this is their dexamethasone dose. Dexamethasone is the cruelest thing that we do to these patients. So it causes diabetes, it causes weight gain, hunger stimulation, sleeplessness. People get peripheral edema, osteoporosis. It's horrible. So we like to try to get rid of corticosteroids, and Avastin lets us do that. And in some ways, some cynical people would say that Avastin is really the world's most expensive form of dexamethasone, because that's about all it does. So this is a scan, and that's a tumor, and then it seems to go away. And the reason it seems to go away is that the tumor has leaky blood vessels, and Avastin normalizes them. It's called the vascular normalization process. So those formerly leaky vessels that allowed gadolinium contrast to appear are gone, and the question is whether that angiogenic effect has any effect on the tumor biology. And I think the jury's a little out on that because we haven't had properly controlled trials at recurrence to know that. But it's clear that that helps patients. If you have that and the edema is gone, people do feel better with it. But Bev fails, and usually in most people between 4 and 8 months is about how long it'll work. 20 or 30% of patients have primary resistance and never respond. Half of the patients just have the tumor gradually increase, the enhancing diseases increases. And some people have a very interesting pattern of recurrence where we don't see the angiogenesis, but we see infiltrative tumor escaping from bevacizumab. So we think it switches the tumor glioblastomas like to grow through angiogenesis primarily, and when they're not able to do that because they're blocked under the influence of Avastin, they can become very invasive. And that's where there was hope, and there still is hope, to try to find an active agent against the invasive pattern that could be paired with Avastin. And glioblastoma is the only cancer indication where it's used as monotherapy. In all the other diseases, there's a partner chemotherapy drug. I think that might be why we're seeing that pattern of invasive escape, if you will, from Avastin. We don't have a partner for it, and there's nothing that works after it. So once a patient has Avastin, that's it. That's their last therapy. We can sometimes reoperate, but the patient has to be off Avastin for a month to make it safe so that it can be wound healing, and then after the operation, they have to be off it a month. And if you're on Avastin and then off of it for 2 months, likely it's not very pretty at the end of those 2 months because the tumor grows, because the Avastin hasn't been around. So surgery is problematic. We offer salvage radiation therapy. Usually, though, these tumors recur right where they started, where the high-dose radiation already was. So salvage radiation usually creates radiation necrosis, which is just a mess for the patients, and their scans look horrible. So there is no treatment that works after Avastin. That's probably the #1 problem in our field right now, is to find something that works. Lots of things have been tested, lots of partner drugs. So there's been bevacizumab plus X trials of any targeted drug you can name and any chemotherapy you can name, and none of them have shown any signal of effectiveness. This was one of the ones that held the most promise because there was a small study from the Netherlands that showed that bevacizumab combined with lomustine, so two of our only drugs that work, showed that they are synergistic and patients had better outcomes. So they took that small trial into the European Organization for Research and Treatment of Cancer, the EORTC, finished the trial, and unfortunately, as you're getting used to seeing, completely overlapping survival curves with no advantage of bevacizumab added to lomustine, and no difference even in MGMT. So the patients, even with methylation, although there's a little separation of the curves, it wasn't statistically significant, so there still remains nothing for the unmethylated patients. Targeted therapies, we were well positioned in our disease when the Cancer Genome Atlas was announced through the NIH. The first disease, the first solid tumor that got sequenced was GBM, and that was because of recognition of the desperate unmet need for therapeutics. So the knowledge of the molecular architecture and the genomics, deep sequencing and genomics of glioblastoma is well known as any other type of cancer. And in the era of precision medicine with things like Gleevec and other drugs, there was so much hope for targeted therapies because we now had identified so many targets, and we've realized all these challenges, right? Is just because you can use an immunostain and find EGFR by immunohistochemistry on a tumor sample, that doesn't mean that that gene is actually working, and it doesn't mean that gene is still attached to its tyrosine kinase receptor, and that doesn't mean that it activates the tyrosine kinase and has the downstream effects that you work. Just because it's there doesn't mean it works. That's a big problem, and a lot of these drugs simply just don't get into the brain, which is largely the reason for failure of most of these drugs, is that they lack blood-brain barrier penetration. And this is kind of a phenomenal slide showing all of the failed drugs. So there'll be a quiz on this later, especially for the people on the webinar. We'll have a little quiz. So this shows the ones that are active against angiogenesis, so principally through the VEGF mechanism, and then others over here that are also through VEGF, and then more commonly all of the receptor tyrosine kinase inhibitors, either through the PI3 kinase, AKT, mTOR pathway, or the RAS-RAF pathway. And without going into it, these tested as monotherapy, as combinations. Often the combinations are very toxic. There's a lot of skin toxicity, joint toxicity with them, but none of these have broken through into practice, unfortunately. And here's where it can be frustrating. In the case of a drug that actually gets through afatinib, which is an EGFR inhibitor and a HER2 inhibitor, and it's oral and it's an easy drug. This was a patient, one of the patients from my practice who was in the study, who had this enhancing tumor here that essentially seemed to disappear, and all of this, what's called flare, which is the edema surrounding a tumor, and significant improvement in edema, and that happened just over 8 weeks of treatment, but unfortunately that relapsed very quickly. and this trial overall was negative. And I'll show you some of the data here to show how disappointing these drugs typically are. Don't look at the whole thing, just look at the top row here, which shows for the targeted drug alone, progression-free survival of 6 months. Remember I said 20–25% is kind of the bar you want to hit. So 3% for the drug alone. For the drug combined with temozolomide, so temozolomide rechallenged 10%, temozolomide alone 23%, just like we had seen from prior data. So the targeted inhibitor dragged the whole study down rather than working, even though it got into the brain, even though it shrunk tumors. At the end of the day, very few patients actually had durable benefit from the drug. Selengitide was a major disappointment. It's a simple integrin inhibitor. We thought it would be a great partner for angiogenesis inhibitors in the lab. It works beautifully in combination with radiation. So these are in orthotopic mice. This was Tom Mickelson, who was at Detroit, and he's now joined us in Toronto. And these are animals treated with control or with selengitide alone. These are animals with radiation. On the top, the combination, it looked like animals were living virtually forever. And you can actually target it. You can find it. That's a PET scan tagged with a marker that can show the integrins. And when that gets resected, you can see robust expression of the target. And studies were done to look at the effects of selengitide, and it was noticed that it appeared to work better in patients that had methylated MGMT. Even though selengitide isn't an alkylator, it has nothing to do with, it doesn't require MGMT to work. It's not a resistance mechanism, but for whatever reason, it seemed to be a little bit better compared to historical controls. And those historical controls were from the Stupp study from 2005, where there was about a 14-month median survival. And over the years, you'll see as a theme through this that the survival rate for glioblastoma has sort of gradually increased. So these days it's more like 17 or 18 months rather than 14. But at the time, it looked like there was a little bit of a bump and some signal there to go forward with a phase 3 trial. And it looked as though it didn't work at all in unmethylated patients. And I think this is an important slide just to show where we were at then with development and probably still are now. So that this was when we were planning this trial. Patients were stratified according to their methylation status, and the patients that were methylated got into the trial and got selengitide in addition to radiation therapy. And on this side of the box, it was left as agent to be identified. We were very unhappy with this. You know, the idea of going into the clinic and telling patients, look, you've got a recurrent tumor, or in the upfront trial, you've got a glioblastoma. We want to test for MGMT, and if you've got this, we think you'll respond to this drug and you should be in the trial. If you don't have it, we don't have a drug for you. And not only that, your prognosis is much worse, right? It's a favorable prognostic marker regardless of treatment. Methylated patients do better. So we weren't really happy with the idea of approaching patients in clinic and identifying the 40% that were methylated and offering them a trial and having nothing for the others. So what happened was the step was taken to offer dose-intensified selengitide, kind of like back to the RTOG-0525 trial, where more might be better and you might overcome this. So that's what was done. So the trial was done so that the patients were methylated, they got into one study, unmethylated, they got into another, and both were negative. So there was no benefit from selengitide, and the drug's been dropped. So lessons from that, right? Here's a highly expressed target. It's easy to see. You can even do a PET scan and see if you have the biomarker for the drug. And there was clear preclinical activity. It was a really good year for mice with brain tumors. It really worked. And there was no dose-limiting toxicity. And that might have been an issue. So the dose of selengitide could be given. You could give as much as you could give barrelfuls of selengitide, and nothing happened to the patients. So in some ways, we didn't really know the right dose. But here are the problems, right? There were no controlled trials done. So the phase 2 trials were not controlled. It was just a guesstimate based on historical controls that it looked like there was enough signal to go forward into an expensive phase 3 trial. And then the efficacy was suspected in methylated patients, whereas methylation has nothing to do with the way that the drug works. And they were selected for MGMT status, not for target expression. So it all seems kind of obvious and stupid in retrospect, and yeah, it was. What can you do? So why these failures? One of the things is it's very hard to tell if the drug gets into the brain. It's very different than other cancers and systemic therapies where you know that, you know, if you give IV Taxol, it's going to get into the area of breast breast cancer, for example. We just don't know if things get through the blood-brain barrier. And as I kind of started at the beginning, there's a whole bunch of this disease that's beyond what we can see on imaging. So it's very hard to target. It's very hard to see. If you're hitting it, you can't tell on an MRI if that stuff's getting better, worse, or the same, because it's invisible to us with current technology. The new era, so the targeted era is kind of done. The new era are the vaccines and checkpoint inhibitors, and the idea is that all cancers have a variety of ways to avoid the immune system. The immune system would tend to recognize cancer cells as bad guys and try to eliminate them, so the cancers have got all kinds of mechanisms that they've, through their genetic evolution, to avoid the immune attack, and they're listed there. And the strategy really with all of these treatments is to teach the immune cells how to find the cancers and how to recognize them, so to trick the immune system or teach the immune system with a variety of different types of cells. And one thing that's a problem in targeted inhibitors is this issue of heterogeneity. So, you know, the EGFR target, for example, is present in 30% of glioblastomas, but when you look within a glioblastoma, there's some areas that have EGFR and other areas that don't. It's very heterogeneous. So if you don't have a target that actually is pervasive and throughout the tumor, you're probably not going to have a successful therapy, whereas heterogeneity might be the way that the immune system can evolve, because it's going to be uniquely capable of attacking at the various immune checkpoints. And this is why people are very keen on multi-target immunotherapy approaches. So vaccines that aren't just a single peptide, but are 6 combined peptides, or actually a gemisch of brain tumors, so human brain tumor is removed, and the thing is pulsed up and made into a vaccine and given back to the patient, so they have an actual vaccine against their own tumor. And I won't go through this in any detail, but I'm sure people are well aware that in cancer now, the PD-1, PD-L1, and CTLA-4 checkpoint system is under a huge amount of investigation, with very exciting responses that are seen, particularly in melanoma, even malignant melanoma. You know, President Carter is a great example of that, with brain metastases on checkpoint inhibitors and having them just completely wiped out. And these are sort of the brakes and the pedals on the immune system, if you will. So some of these targets turn off the immune system, some turn them on. So this is a way of leveraging the immune system. Importantly, down here, which you can't read, I don't expect you to, it doesn't matter, but this is a diagram that shows the mutation frequency in different cancers. And so cancers that harbor a high level of mutations are much more likely to be sensitive to checkpoint inhibition. And so on this end, which you can't read, I'm sorry, is melanoma and lung cancer and renal cell cancer, and those are the ones that are getting FDA approval for nivolumab and some of the newer PD-1 and PD-L1 inhibitors. And the red box is where glioblastoma lies, somewhere in the middle. So maybe with our disease, the future would be trying to measure do mutation profiling and select patients with high mutation profile phenotypes and enroll them into clinical trials. Because so far, with these drugs in GBM, it looks like monotherapy virtually does nothing, and the way forward is going to be combination treatment. There are a variety of trials. These are some of the early ones, so there's nothing really to say about them. They've just started with Pembro, with Nivo and durvalumab, and they're just undergo. And these are the more advanced ones that you'll probably be hearing results this year at ASCO in June, and at the Society for Neuro-Oncology in November. I would imagine that these are going to have some data. We've seen some safety data from 143, and it looks to be reasonably safe, but it's too early to know about efficacy. And in general, these things as monotherapies have not been all that successful. So these are the combination studies. It's just a laundry list of them. There's tons of them going on. So there's combinations with radiation, with targeted inhibitors, with other checkpoint inhibitors, and people are just going to town and trying these different combinations, and none have any data reported yet. So there's oncolytics. Those are different. Those are biological agents that get into cancer cells and cause immune stimulation. So these are things like gene therapy and viral therapy. Often these are things that have to be given at the time of an operation injected into the tumor cavity. The exception being vascular biogenics 111, which is a really cool idea. So it's a modified viral gene construct that's given IV and actually gets into the brain and triggers anti-angiogenic mechanism in the brain. That's currently in a phase 3 registration trial that's completed accrual, so probably in 2 years we'll hear some information from that. These are the vaccine trials. Northwest Biotherapeutics was in the news lately because the FDA released the hold that it had on that clinical trial. So it's going forward collecting data. They've collected enough data to know progression-free survival, although that's not public yet. And they're awaiting more deaths, more events to see overall survival. ICT-107 through immunocellular is ongoing. That's a 6-peptide vaccine, so that's one of these off-the-shelf vaccines as opposed to the Northwest Bio. Northwest Bio needs fresh tumor tissue taken out from the time of the operation, shipped to their lab in Memphis, put together with apheresis product from the patient's peripheral blood, and it's mixed and made as a vaccine. So about 75% of the time they can make a patient a vaccine with this technology. So it's their own tumor. And other work like that mixes not only the patient's particular tumor, but takes a bunch of antigens from other patients' tumors and mixes them in and tries them as vaccines. So nothing will be out very soon. This, though, I'll talk about the rindapepimut trial, which was of a single peptide, and I think that's important when you look at this list. So it had one target, EGFR-V3, that was the only thing it inhibited. And if I kind of think of these pathways all like a superhighway, right? So if you're on the interstate and you block one lane, the traffic still gets through, right? The tumor still grows. You'd have to block all the lanes, and the issue in GBM is how many lanes are there that are truly important. So you're going to have to be able to have combinations of multiple things that block the pathways, and that's likely the reason that this trial didn't work. So rindapepimut is this EGFR V3 peptide vaccine. It was developed through Duke, principally through Daryl Bigner and John Sampson, and it's very easy to use. You get a primer vaccine, and you get vaccinated on a monthly basis, and it is very simple with few side effects for patients. And the reason our field got so excited by this is that these are paired samples. So this is a patient sample from their first craniotomy and resection, and this is at the second craniotomy for recurrence after the patient had received the vaccine. So the EGFR as a whole is expressed, all the brown stuff, or so-called brown stain, is EGFR, and it's the same, but EGFR variant 3 disappeared. So it looked to be pretty clear that if you got the vaccine, you could make the target disappear in the brain tissue, which was very cool to see and very exciting and promising, and everyone got behind this in a big way. In the prior studies before the phase 3, the ACT 2, the ACT 3, the ACTIVATE studies were compared to historical controls. So there's that lesson again. So those historical controls look good, though, 24 months of median survival. So even if you compare to the modern numbers of 17 or 18 months, that still looks like 6 months more. But these were patients that had gross total resections, who got through chemoradiation and were perfectly stable without any tumor growth, and they had V3 expression. So it's a very select subset of glioblastoma patients, probably 10% of patients that would be eligible for this. And then in the setting of recurrence, they combined it with bevacizumab and saw a more interesting potential signal there, which I'll come back to. So ACT 4 was the potential registration study for this compound. It's coming out in press in a couple of months, but was presented at the SNO meeting in November. I won't go over the design. Patients got either a peptide in a vaccine or a placebo vaccine. And in the overall intention to treat, the overall trial results were totally negative. Median survival 17 months. You can see how it fell down way below the 24 months that they thought. And this is called the minimal residual disease population. So those are folks that had gross total resection. So it was 20 months there. So it was even an overestimate from the original uncontrolled data. And then what was interesting is investigators weren't all that good at only enrolling patients with minimal residual disease. So a lot of patients got enrolled in this trial that had residual disease around the cavity, so incomplete resections. And interestingly, those patients did the best. So there was actually statistical significance in this unplanned subgroup analysis for patients with bulky disease, probably because they had more tumor antigen around to stimulate an immune response. So there's still, the drug may not be dead because they may be working on looking at how this is going to play out in the real world. What's really interesting, and again, hard to read here, is this tiny little box that shows that over the course of time, when there were paired samples, I showed you before how it looked like the EGFR V3 got knocked out by the vaccine. It turns out that that happened in the placebo group too. So that's just a part of the natural history of the disease, that it's an unstable antigen and it disappears as part of the natural history, so that the immune target is lost. So that's another reason this may have failed, is that the target's there at the first operation, but it gets lost over the course of time. So what was really, really exciting turns out to be just a part of the natural history of the disease that just wasn't appreciated when the trial was designed. So combination approaches are the way that the field is going. And it's a little confusing if you think about it. So there are trials that combine immunotherapy with surgery, but if there's less residual disease, there's less tumor emanating immunosuppression, but less antigen load. So we're struggling with who are the optimal patients to treat. There's radiation in immunotherapy because radiation may release tumor antigens, but radiation also kills lymphocytes. It's a really great way to kill your helper lymphocytes, your CD4 cells. So it mitigates the immune response. Chemotherapy, same thing. Temozolomide is a CD4 specific toxin, so it knocks your CD4 count into your boots. Some people at the beginning called it iatrogenic AIDS because that's the main way you measure how immunosuppressed a patient with AIDS used to be, how you measure things. So that's paradoxical. And VEGF is very immunosuppressive, but it restores the blood-brain barrier, as I showed you from those pictures before. So all the lymphocytes and traveling things through the system aren't going to be leaking out into the tumor anymore. The REACT trial is interesting. The first part is going to be reported out, well, was reported in part at a recent meeting and will be a paper soon. So this is at recurrence bevacizumab combined with rindapepimut. So this is, I guess, the first thing that's ever been shown to work with bevacizumab. So patients were randomized 1-to-1 to get the vaccine plus bev or get placebo plus bev, and it showed modest but impressive improvements in progression-free and overall survival. And those are preliminary data that were presented at ASCO by Dave Reardon, and Michael Weller was one of the discussants. So that paper is currently under preparation. So that's coming. Just a brief word on this thing, the electric yarmulke. This tumor treating field. So patients shave their head and they get electromagnetic strips on their head. And they cost $20,000 a month. And these are placed over the head in a particular orientation to give a higher dose of electromagnetic energy to the tumor. And it comes down through some wires to about a 4-pound battery pack with a battery life of about 5 hours. And the patients have to wear that. In the trial, they were asked to wear that for 18 hours a day, but the motivated patients wore that usually for 22 hours a day. They basically just take it off to shower. So the EF14 so-called trial, which was the upfront trial, showed impressive results. So the patients that got these tumor treating fields plus temozolomide and radiation had improvements in median survival and 2-year survival, very statistically significant, and it was published in JAMA. So why does nobody believe it? So there's an impressive survival improvement, separation of the survival curves. There's no toxicity. It's a pain in the ass, but there's no toxicity from it in the sense of treatment. And it is a new paradigm for the treatment of cancer. And they are going forward to look at other indications. There's an electric bra, there's electric underwear for testicular cancer. They're going everywhere. One reason there's skepticism is that their very first trial, which was for recurrent disease, was designed as a superiority trial. So I'm not sure if everyone here knows biostats, but when you design a trial for superiority, if the device wasn't better, if there's overlapping survival curves, like I've shown you over and over again here, then that's a negative trial. But they took that superiority design trial, showed the overlapping survival curves of chemotherapy, and claimed that it was equivalent. But you can't do that. So a trial of equivalence takes thousands of patients, not hundreds of patients. And so that created a lot of skepticism in the academic world, because there was a claim that this thing worked as well as chemotherapy, and it was actually a negative clinical trial. The other problem with this study, the EF14 trial, is the patients were randomized. So they were approached, they wanted to get the device. Half of the people got the device and wore it and were highly motivated, wearing it 20 hours a day. They're visited at home by a technician from the company, because the electrode arrays have to be replaced on a monthly basis. And they came to the clinic much, much more often for checkups than patients that were just left to standard care. And I'll just remind you of a paper, a very important paper in lung cancer not that long ago, that was just a randomized trial of showing the effect of the introduction of palliative care services earlier. So no treatment, just increased care. And survival was 3-4 months longer. It was clinically significant. There was more effective introducing palliative care in lung cancer than the new targeted therapies in lung cancer. So I think this was a trial of highly satisfied, motivated patients versus disgruntled, pissed off patients that didn't get the drug. And I think 3-4 months is completely unimpressive in that regard. And I think that's why it's not getting taken up by our community, unlikely to be a standard of care. And if payers are starting to look at the cost at $20,000 US per month, the numbers are not going to work out in an economic analysis where you look at quality adjusted life years, etc. Am I good for time still? Yeah, so that's that. So where next? So despite all this stuff, we're still left with surgery, radiation, temozolomide, a little bit of lomustine, a little bit of bevacizumab used to palliate symptoms. And these strategies do very little for those 60% of patients, the majority of patients with GBM with unmethylated MGMT. So I think the most urgent unmet needs in practice is an upfront agent instead of temozolomide that'll be effective in unmethylated GBM and effective treatment after bevacizumab. Those are the key weaknesses in our space right now. We've tried to overcome the disadvantage of having unmethylated MGMT by giving stronger, dose-dense temozolomide, which depletes intracellular MGMT. You can inhibit MGMT with 06BG, 06-benzylguanzine, but it doesn't work. You can interfere with a different repair mechanism, base excision repair with PARP inhibitors, but none of them get into the brain yet. New cytotoxic agents that don't work through the 06 position, that work through other positions to cause alkylating damage are very hopeful. So this shows that issue that temozolomide is going to work when MGMT promoter is methylated and there's not much MGMT around. And if there is, DNA repair can happen, and the tumor can still propagate. So strategies are to deplete MGMT or give 06BG. And down on the other side, where in the absence of a new cytotoxic agent that works in the unmethylated situation, it would be ideal to have one that worked on N7 rather than 06. These would be the PARP inhibitors or other new agents that are coming. But that's again 60% of our patients. We tried doing this with altering temozolomide schedules. You can show that you can measure the MGMT level in peripheral blood, and if you give daily temozolomide, MGMT disappears. So in theory, you can overcome the disadvantage. And we did this in a phase 2 trial in Canada called the Rescue Trial, and got decent progressive-free survival, like 27%, 35%. It didn't work really well if patients had been on extended, so meaning a year or more of temozolomide. Typically, people were given 6 months, and then if they were well, they got a treatment break and when re-challenged, had decent PFS6, but still not as good as we'd like. But maybe that's one strategy that helps a little bit to overcome MGMT. 06BG was really hopeful. It's largely through Duke that this was done. And the problem with 06BG is that it is myelotoxic in and of itself, and you need to reduce the dose of the chemotherapy you give it with by 50 to 80%. So some studies have used it with BCNU, and others have used it with temozolomide, and the temozolomide dose has to be dropped 50%. So these studies didn't show any activity, and half of the patients got grade 4 neutropenia. So grade 4 neutropenia is like neutropenia in your boots, sepsis, admission to hospital, terrible, unacceptable toxicity with no benefit, probably because the dose of the effective drug had to be dropped so severely. So we're left with the search for an ideal systemic therapy. So what would I like to see? I'd like to see something new that's oral, or at least a simple systemic schedule with minimal drug-drug interactions. That's a real problem in clinic because a lot of our patients are on anticonvulsants and things that go through the liver and cytochrome P450 system, and it can chew up a lot of effective drugs. Obviously, we want there to be unequivocal anti-tumor effects, ideally up front for newly diagnosed patients at recurrence, or crucially in this post-Avastin failure. Obviously, for the patients, tolerable toxicities. Ideally, a biomarker to select the patients. So unlike the selengitide experiment where there was no proper biomarker, have a biomarker that you can test the patient for in this area of precision medicine, test the patient for and apply the appropriate drug. Ideally combinable with other agents, because if you block just one lane of the highway, you're not stopping traffic, and it should be cost effective. So with that, I'll let others take over, and I think we'll entertain questions after all the presentations. Thanks for your attention.
Great. So hi, I'm Anne Steino. I'm the preclinical director at DelMar Pharmaceuticals. I'm going to start with the same slide that Dr. Perry just ended with. As you all heard, it's a pretty daunting task to move into GBM, and you might all be thinking that we're crazy to try to do it. After this, I'm going to try to tell you why we're not, or why we don't think we're crazy, and why we think we can overcome a lot of the problems that Dr. Perry just described, and why there's a scientific rationale with this drug that might hopefully lead it to be successful in these patients. So this is something we've presented, the new paradigm that we're anticipating or hoping will come out for the GBM patients, where I don't know if you can hear when I'm looking this way. You get diagnosis and then surgery and then MGMT assessment, which is becoming more and more common at most big cancer centers. And then the 1/3 that have MGMT methylation, as Dr. Perry described, they will get temodar or temozolomide with radiotherapy, and then at tumor recurrence, potentially get VAL-083. And the 2/3 that express MGMT up front already, well, you might actually just decide to give them VAL-083 with radiation at that point already. So VAL-083 is an orally bioavailable small molecule. The current formulation is IV, but we're working on that. It has historical, lots and lots of NCI-sponsored trials from the 70s and 80s. There's great activity in brain tumors, easily crosses the blood-brain barrier. And then we recently did a phase 1/2 clinical trial that shows is well tolerated. There is low toxicities, and in the higher doses of that clinical trial, there was actually also activity. I'll show you later, but it's a small trial. Keep that in mind. It was well tolerated. It's a simple dosing regimen. You come in 3 days of a 21-day cycle. MGMT methylation is completely irrelevant for the efficacy of this drug as far as we've seen so far, so we might actually be able to overcome this MGMT problem that so many of the GBM patients face. And it's potentially combinable. I mean, the more we understand about the mechanism, the more we sort of learn that there is rationale to combine with other agents. So this is historical trials of adding a chemotherapy to radiation in glioblastoma patients, and this is not one trial, so it's difficult to compare, but I talked to Dr. Perry about this earlier, and as he said, around 2 months is very common to see if that's the benefit of just having radiation or the benefit of adding a chemotherapy to that. You often see around 2 months, so 8 months is very impressive if that is the case, and these are historical trials, so obviously we need to work on that. This is the DelMar phase 1/2 trial that we just finished last year, and again we saw an actual benefit of like over 8 months, which is really impressive if that's the case. So we're moving into a phase 3 trial, obviously with more patients, to see if this is actually gonna hold up. These are just the toxicities. So the dosing regimen we're moving forward with is 40 milligrams per meter squared daily for 3 days in a row, and then you have a 21-day cycle of this. There's mild myelosuppression with this dosing regimen. It resolves spontaneously when you stop treatment. It's mainly thrombocytopenia, and there's no other severe adverse events. You just have mild myelosuppression. So this is really my field. I'm the preclinical director, so I'm going to talk more about the mechanism and why we think it can overcome this MGMT problem. So if you have the 2 strands of DNA and you have guanines sitting on both strands in close proximity, which you often have, VAL-083 targets the N of the guanine, whereas both the CCN-urolomastine and temozolomide targets the O6. So if you have these 2 guanines sitting on opposite strands, and then you have our small molecule crossing the blood-brain barrier, it targets this N7 on each side and creates like a staple. So it basically just staples the 2 DNA strands on each side together. And now the cell's going to try to repair this. And what happens, like Dr. Perry said, you have about 10,000 incidents of DNA damage to each cell every day. And so the cell has all these different ways of repairing it. And if it has the capacity to repair the damage, the cell will survive. And that's what happens when you have MGMT present. You induce damage with temozolomide, but the cell just repairs it and keeps living. So if you can induce damage that either is so much that the cell can't repair it, or that you have it goes around the pathways that are able to repair it, you can get the cell to go to apoptosis, which is what we want in chemotherapy. I'm just going to get my water. So thinking back to what I said before, that you create this staple, this is the DNA, you create this staple, and then the cancer cell will try to divide, as they often do, all the time. And it goes through the cell cycle of division, and when it gets to S phase, that it needs to divide, it needs to create a replica of the DNA strands. So it tries to separate these DNA strands that are stapled together. And what happens is that machinery moves down the train tracks of the DNA, and it hits these staples, and the whole strand just breaks apart. So we have now a double strand break, which is like the most severe form of DNA damage to a cell. It's very hard to repair. It can be repaired through this pathway, the non-homologous end joining. I'm not going to go into it because it is not, in our case. It's repaired through this HR repair pathway. All the ones that are in red here, it's obviously more complex than this, but all the ones that are in red are the ones that we've shown get activated after VAL-083 treatment. Just 1 hour of treatment, you remove the drug, and these are activated for over 48 hours. And this is a glioblastoma cell line, but we have data from all kinds of cancer cell lines. So we know this pathway gets activated, and by that we know which drugs that it can be combined with and other things, but especially we also know that it overcomes MGMT. So like was shown before, temozolomide is given, it creates these O6 methylations. If there's high MGMT, the cell will survive. There's treatment resistance. Even if you have low MGMT, as the 1/3 of the patients that are lucky enough to have this, you still need to have an MMR mismatch repair, DNA repair system that works. If you don't have this, and is a very common mutation in many cancers, you again get treatment resistance. But, so for the patients that have low MGMT and proficient MMR, well, temozolomide works. But what are we going to do for all these other patients? And so this is VAL-083, this is temozolomide or Temodar, and this is just a show of they both target guanine, but they target 2 different places, and this is where MGMT repairs. So the scientific rationale was, well, we have a completely different target, so it should be able to overcome it. And this is just the STUB trial that Dr. Perry showed before. So we started by looking in 3 different glioblastoma cell lines that have different MGMT profiles and different resistance status to temozolomide. And if we convert these curves into IC50 values, you'll see the IC50 values for VAL-083 completely independent of the MGMT methylation, are all showing IC50 values of under 5 micromolar, which is totally clinically achievable in the brain. Temozolomide, on the other hand, especially in the high MGMT cell line here, you don't even get an IC50 value because there's absolutely no activity. So this was very encouraging. We did just this one animal study in a mouse with a glioblastoma tumor. It's more than anything just to reconfirm that it crosses the blood-brain barrier and it works. The reason 5 milligram per kilogram is not shown up here is because it was too high of a dose for the mice. So instead of getting the full 9 doses, they only got 4, and then we stopped, and they came back. The toxicities resolved on their own. They didn't get any therapy, and they still ended up having a significantly better median survival, even though they didn't actually receive the full course of the treatment. Another thing that's a huge problem in glioblastoma treatment is the occurrence of cancer stem cells. So this is sort of a field that's taken off in the last 5-10 years. The idea that a tumor is heterogeneous, so there is different types of cancer cells, and the red ones in the middle are the cancer stem cells. And so you hit the tumor with chemotherapy, radiation, whichever, and you kill all the white ones, but you have a little cluster of cancer stem cells or tumor-initiating cells, they're also called, and the tumor will actually just recur after treatment, and you'll often get a more resistant tumor recurring. So our fabulous partners at UCSF did these studies with primary patient-derived glioblastoma cell lines, and they grew them. There was MGMT positive and MGMT negative, and they grew them as cancer stem cells and paired non-stem cells. And so what we saw, this is just one of the cell lines. These are the cancer stem cells, non-stem cells, and both MGMT expressing. And as you can see for temozolomide, there's no effect. Up to 200 micromolars, there's no effect. And for VAL-083, you see a great effect in both the cancer stem cells and non-stem cells at low doses. And we did all these other patient-derived cell lines as well, and independent of MGMT, independent of their cancer stem cell status or not, it worked. This is one study that we did some years ago. This will obviously have to be repeated as well, but it does show, it's encouraging to show that if you combine VAL-083 with Temodar, you see a complete removal of any type of spheres that recome after 2 treatments or 2 passages of these cancer stem cells as well. So this is just a little table I put together sort of showing the mechanistic differences between temozolomide, nitrosoureas, which includes lomustine or CCNU, and then VAL-083. So up front, yeah, the target is different. It's N7, it's not 06, which makes it independent of MGMT. The data we have so far shows that it's likely or possibly independent of MMR, everything, but the final data on that we're hoping to present at AACR, so stay tuned for that. But so far it seems to be independent of MMR as well, as we would expect. It's less dependent on P53, crosses the blood-brain barrier, and basically just, on most accounts, is different from these other drugs that are used in the treatment so far. So if we stratify the GBM population by MGMT and by MMR, we have a drug we think that actually works in all of those patients, whereas the ones that are currently used the most, temozolomide and CCNU, have resistance to MGMT unmethylated, and for temozolomide also is dependent on an MMR. So right now we got about 1/3 of the patients that respond to temozolomide. As I said, they have to not express MGMT. They have to have a functional MMR. VAL-083, we're thinking, will be able to actually target all of these patients. So this is the proposed phase 3 trial that we're hoping to get started on shortly. It's 180 patients. It should be concluded in about 20 months from start of enrollment. So it is surgical resection, and then given temozolomide plus radiation, temozolomide maintenance, and then a recurrence, and then given Avastin or bevacizumab, and then a second recurrence. And this is the population that Dr. Perry was talking about, where there is actually nothing to to offer these patients, and this is where we'll randomize and give a VAL-083 or a salvage chemotherapy. And then we have 2 other studies that are phase 2. One is already enrolling at MD Anderson. Is again surgery and then stratified based on MGMT. And the unmethylated ones, which is the one that don't benefit from temozolomide, they'll be given temozolomide anyways with radiation, and then at recurrence we'll give them VAL-083 and we'll see. And this is already enrolling. And then we have another international trial that's going to be actually upfront. Fabulous partners that we work with and provide us with all this data. So that was it.